刘教授
听到了
您好，听见
啊？
了啊，
行，
您继续讲，
刚才可
您继续。
能后边没有说完哈，因为可
对，
能这个信号的事儿。总的来说吧，我再简单说一下，就是说我们今天这个学术会议的这个内容非常丰富，我非常感动。我们从早上7:45到晚上7:30，并且邀请了很多国内外的这个著名的专家啊，顶级专家进行授课交流，啊，让我非常敬佩和感动。像我们这样的学术组织实际上是不多见的。最后呢，我也是感谢许教授和各位专家的邀请，也祝我们专委会今年在北京能够顺利的成立，也预祝今天的学术大会圆满成功啊！我就讲这些，谢谢许教授。
好，非常感谢刘荣涛秘书长的精彩致辞，也再次感谢您和中国医师协会中西结合分会领导在学会成建过程中的一些支持和帮助。我们开幕式呢就到此结束，下面呢我们开始上午的学术环节，把主持权交给第一节主持人田大胜教授。田教授。
徐老师好。因为时间有点提前了啊，50，不知吴教授上线没有？我来看一下子。吴教授在线上。那么下面就开始啊，徐专。
好的。
啊，
对，田教授，你们从第一节开始的就掌握好时间节奏啊，你们督促一下，辛苦了啊，辛苦了。
好的，我们尽量把时间控制在。
过程中啊，田教授、张伟教授、于可一教授、于中教授啊，都做了大量的工作啊，在此一并表示感谢啊。我们这个筹委会呢，就是为大家搭建个平台，所以今天上午请来的都是国内的知名专家啊，期待大家给我们带来精彩的讲课。请田教授来，由你来。
好的。好，尊敬的周越教授、张建国教授、荣立明教授、刘晓光教授以及线上的各位嘉宾，各位同仁，大家上午好。首先还是感谢周越教授和张教授的对我们筹备组的肯定和鼓励，以及殷切的期望，这将鞭策我们将不断的奋进。在此我们再次感谢各位领导的精彩支持。下面我们进入双通道脊柱内镜专委会筹备组研讨会。第一位发言的是来自新加坡国立大学的吴登峰总医院骨科的吴鹏峰教授。吴教授率先在新加坡开展的 UBE 技术。其实关注 UBE 的大夫对吴教授都不陌生，他真多次在国内的会议上做过有关双通道的专题演讲。今天他演讲的题目是 Vascular Anatomy and hemostasis in endoscopic spine surgery. Welcome, Professor Wu.
Thank you, Professor Tian and Professor Xu, for your kind introduction. And thank you for the organizing committee to let me have this opportunity to share my thoughts on vascular anatomy and hemostasis and endoscopic spine surgery. Introduction of myself, I'm practicing in mainly in Ng Teng Fong General Hospital, highlighted in red, and I'm a visiting consultant in 2 other hospitals in Singapore. My main specialty is endoscopic surgery. I do both uniportal and biportal endoscopic surgery. Initially, in the past few years, I started out with uniportal, and you can see the percentage of the uniportal is getting more equal to my biportal surgery now, and they varies from stenosis, decompression, and cervical cases. We all know that endoscopic surgery started as evolution from uniportal surgery, and they have transited to 4 generations from the transforaminal, interlaminar to now endoscopic fusion as the 4th generation and cervical and thoracic cases. The biportal surgery in tandem also developed over both by the Koreans and the Chinese in multiple in the past decade, and has evolved into all the surgeries that we can include for degenerative cases. One important advantage in biportal surgery is that we can position ourselves in a very similar situation by operating on the cervical, thoracic, or lumbar cases. And recently, AO has classified both the uniportal and biportal and give some clarity of the nomenclature on the various surgery. One of the advantages of biportal surgery, as you can see from this video, you can see that from the lower part of the sagittal and axial cuts, you can see that there's a significant severe stenosis. And more importantly, there is a significant facet hypertrophy. And from the post-op, you can see that we have decompressed the spine adequately, and then we have preserved a large amount of the facet joint for stability. Hence, you can achieve both decompression and stability for the patients. And you can see the paraspinal muscles are largely unaffected. This is a video. Actually, you may not hear the voice, but the patient was commenting that she can manage to go home the next morning because surgery is done in the evening, and then this wound is pretty small. Together, it's just a 5-cent coin of our Singapore coin. Hemostasis is especially important in endoscopic decompression because without proper hemostasis and poor visualization, it can cause damages to our spinal neurostructures. Recently, in our publication in Asian Spine Journal, we realized that in these uniportal reports, the incidence of epidural fluid hematoma is up to 27%. Fortunately, most of the hematoma are asymptomatic. This is a study done for all patients who have undergone the surgery of uniportal endoscopic decompression, and we do MRI for every single one of them. We find that it is a common early post-operative MRI finding, and it's important to address this. As we can see that in a subsequent study, as we done the MRI at immediately post-op, 6 months and 1 year, we find that there is scar tissue remodeling, and we find that there is a significant association with those who have a more severe remodeling of the scar in patients who have epidural fluid hematoma. So it's important to perform good hemostasis to decrease the incidence of epidural fluid hematoma formation. One of the challenges of biportal surgery is a rate screen. As you can see from this video, you might have a situation when there will be basically a rate screen and can see what is clearly of the structure. First of all, we have to perform a plasma coagulation of soft tissue to obtain a good visual clarity for the surgery to continue. In the early learning curve, without good inflow and outflow system, without good plasma coagulation or disorientation in the endoscopic surgery can be quite discouraging for the early learner of the biportal surgery, and many of the conversions in the early period of learning curve is due to rate screen. Some of the causes of rate screen will be soft tissue and muscle bleeding, foraminal bleeding, epidural bleeding, bone bleeding, as well as stagnant water inflow. Overall, to decrease bleeding in open spine surgeries highlighted in this article, in these various top points. Those highlighted in bold are the ones that are applicable to endoscopic surgery. First, we need to discontinue the anticoagulation medications prior to surgery. We tried our best to maintain normothermia for the patient. Maintaining normothermia is important as hypothermic patient tends to bleed. Hypotensive anesthesia is important, and I've seen Dr. Hayati from Turkey. He really maintained it to a very low blood pressure. But for our situation, I think the MAP for less than 65 would be ideal, but for spine, probably above 80 would be suitable for neuro elements. In optimal positioning is important. I'll highlight that later. Although we can't use the electrocautery, but we can use we can dissect the intermuscular plane and subparietal plane using our plasma coagulation to maintain hemostasis. There are other things like gelatin sponges, bone wax, and flowable agents that we can highlight in this situation. So these are the drugs that we need to stop. I think we're all familiar with this. I will go on with that. In terms of positioning, the ideal would be that we position the surgical side be higher than the right atrium. Of course, it's not possible in all situations of endoscopy, as we try to position the endoscope and working and viewing portal mainly parallel to the end plate. So in a situation like that, we try our best to maintain the transdental position. Keep the right atrium below the level of operation will help in decreasing bleeding. And of course, decreasing intra-abdominal pressure by using either Wilson frame or Proaxis table. These are videos showing various ways of maintaining good inflow and outflow for the patients. You can either use it with a good dissection. We can make a cut, be it in a vertical and subsequently in an oblique situation, to maintain a cut that allows the inflow and outflow with a good muscle dilation, as we can see in this video. Another way that I could practice in my institution is to use the two cannula. One is we call it endosize, the viewing portal, and the other one is the outflow portal. You can see the water is flowing out from the outflow portal very well. So in terms of the lumbar spinal vascular anatomy, I think one of the common artery that we encounter is the superior articular artery. If we do our UBE or BEST in the interlaminar window and we drift outwards too much towards the lateral aspect of the facet, we may encounter the superior articular artery bleeding. So try our best to stay in the interlaminar space. As we dissect around the facet joint, we can see usually the edges of the facet joint may have significant bleeding in the inferior articular artery. In the fusion surgery, we can sometimes drift too much, not upwards, more Catholic direction and get interfered into the interarticular artery. So stay in the interlaminar window. It both helps in minimizing soft tissue dissection of the multifidus muscle, and then also decrease the bleeding of encountering superior articular artery. When the far lateral approach, we do try not to breach the intertransverse membrane, when we can get into the radicular artery bleeding. So this under the scope, you can see all these arterial bleeding on vessels very clearly. And you can see that these are the main areas that we can bleed for: muscle, arterial, and then the epidural vessels. Hopefully, we do not get into the vascular surgeon's arteries, and we tend not to when we are doing biportal surgery, as we have clarity of vision. It's an article published in Neurospine, and I think some of the points are important. Bone wax is suitable for bone bleeds where the blood flow is low. And another point is that bone wax, when we come to fusion, it may affect fusion. So we do not put bone wax on the fusion surfaces, as it can affect fusion. If there's a small ooze in open surgery, we can use sponges such as gel foam. In biportal, we can use a gel foam with a bone wax, what Dr. Choi mentioned as a push block technique. For the moderate bleeding, we can use hemostat flowable hemostat such as FlowSeal, which I will highlight later. And I tend to use tranexamic acid in most of my cases, except for patients who have a history of stroke, heart attack, as well as other bleeding, DVT, as well as other bleeding problems. Surgiflow or FlowSeal are flowable hemostatic agent that we can use according to your institution practice. So these are the tools that we can use, and then various companies such as Bones have produced good plasma coagulation as well as radio frequency ablator, and then FlowSeal as well as Surgiflow can be used. In terms of plasma, basically the electrode tip is immersed in a saline solution, which is like produce the orange light steam and plasma energy. This saline solution has an important role as it accelerates the sodium towards the electric field and allow the breaking of the molecular bond within tissue, as well as stopping bleeding at lower temperature of 40 to 70 degrees. while we can achieve cutting ablation, vaporization, and coagulation of hemostasis of soft tissue. This is the closest thing to Street Fighter Hadouken that we can do as a spine surgeon. And you can see from the plasma coagulation, we form a plasma bubble, and these bubbles accelerate toward the tissue, causing molecular bond breakage. Hence, when we do plasma coagulation, you can see bubbles in our endoscope. While radiofrequency ablation produces very local heats around the tissue, and while laser a little bit more tricky in terms of stopping bleeding, I think it is mainly used for cutting of the ligamentum flavum, and there's significant safety issue to surrounding tissue and instrument size. So these are clinical videos of how we stop bleeding. This is a muscle dissection using plasma coagulator in bipolar surgery. You can see that using the cutting mode, we can cause molecular bond breakage and shrinkage. If we press the blue button, which is the coagulation, then there's more of a shrinkage of tissue rather than the bursting of molecular bond and cutting. So if you want rapid dissection of soft tissue, I think using the yellow button in bones or most of our technology uses the yellow button that breaks the molecular bonds better. And while we can also use this type of plasma coagulation on soft tissue, you can either use the blue for shrinkage or using the yellow for cutting. In terms of bone surface bleeding, osteoporotic patient, especially, we need to prepare bone wax. You can see actually in early dissection that if you have this cheese hole-like architecture in the bone, they tend to be very osteoporotic and you expect more bleeding. So in this type of situation, there are two things I usually do. I will usually open up the flow seal on standby because I know at the end of the case, I would like to use a flowable hemostat. And then at the same time, I will prepare bone wax for stopping of bleeding. This is a video on showing how we can apply bone wax. I think there are many innovative ideas from especially China that has other bone wax application devices. Here we use basically the back of a curette to put the bone wax on the bleeding surfaces. And mind you, if you are doing fusion, don't put bone wax on the fusion surfaces because it may affect fusion. In terms of vascular geometry, I think we have talked a lot about the arterial bleeding, and then we have to focus on the epidural veins and artery. So these are the radicular artery I've highlighted earlier on. And in the interlaminar approach, these are slides courtesy of Dr. Choi, is really nice, and I adopted it for this talk. And you can see the interlaminar approach. After you have done the decompression, you can see the epidural bleeding in the interlaminar state, in the interlaminar space. We tend to see basically a crossing vein that crosses around the pedicular area just next to the exiting nerve, traversing nerve roots. And then there will be one that's closely adhered close to the exiting nerve root as well. I will highlight that when later on the fusion slides. And then in the far lateral approach, you can see from this slide that you can see that there will be epidural vessels that are quite close to the exiting nerve roots. And this also helps us leads to where the disc is. So by taking hemostasis of these epidural vessels, actually these are also connecting veins. They have connecting tissue that are actually adhered to the disc. So by doing hemostasis, actually allow more maneuverability of the nerve roots. So in terms of contralateral approach, when you are looking on the contralateral side from the left to right, after you take down the superior articular artery, I find there are two vessels. One is the crossing vein that crosses around the traversing nerve root. One is basically a vessel that's quite close to exiting nerve root. I find that this vessel that is crossing the traversing nerve root can be easily coagulated by using the plasma coagulator or radiofrequency ablation. However, on that, sometimes it can be a little bit tricky. So sometimes I use the flowable agent to stop bleeding that is close to the exiting nerve roots to prevent any post-operative dysesthesia. So this is the highlight of the rotatory vessels and the crossing vein that are close to the our neural structures. So this is an intraoperative video. I think this, when we do T-leaf, after we take down the facet joint, we can actually see the vessels very well. So this is a right-sided L45 bipolar endoscopic fusion. As you can see, once we have taken down the facet joint, you can see that this space and the peridiscal epidural vessel structure. First, we stop the one that is close to exiting nerve roots. And then this is a particular vessel that are almost just inferior and parallel to the exiting nerve roots. We can use the plasma coagulator. I use the lower energy setting. I typically put it as 3-3, as 3 cutting and 3 coagulation. You can use higher energy setting if you are comfortable. And then we can stop the bleeding next to the exiting nerve roots. Followed by that, we will I use a hook or straight plasma coagulator to stop the bleeding around the axilla of the nerve roots. As you can see here, there are typically abundant vessels, especially in patients who have spondylolisthesis and other inflammatory distal conditions over the period of degeneration. And they tend to have a lot of connecting adhesions. So taking down this vessel also increase the maneuverability of the traversing and exiting nerve roots. Although in this situation of endo T-leaf, this bipolar fusion, we just need to maneuver gently the traversing nerve roots. So this is showing just the radiofrequency ablation. In the limitation of time, I will skip it. So this is the traversing arm of the rotatory vessels, and it's quite close to the traversing nerve roots. And this is the exiting arm of the rotatory vessel, and that is quite close to the exiting nerve root. By doing hemostasis, we can maneuver the nerve and we can have a clear view of the disc. There is an axillary portion. I tend to be more careful in this. I use a hook radiofrequency ablation or and use the lower energy to prevent dysesthesia. And then finally, you can see the peridiscal capillaries. And the beauty of biportal surgery is that you can see all these vessels very, very clearly. In terms of flow seal, they are flowable agent. They tend to form a clot and activate fibrinogen to fibrin and then form a fibrin clot. This is the case when we do revision. Sometimes there's a lot of scarring. We are not too comfortable after we have done the discectomy in terms of when the hemostasis to apply to the radiofrequency ablation to some of this neural structure which is stuck with scar. So using a flowable agent, after we wash it off, you can see that the bleeding areas are actually tagged on with fibrin clot that's formed by the flow seal. We tend, when as spine surgeon, we tend to be not able to sit still, but give it 2 minutes to 1.5 to 2 minutes to for flow seal to work. I used to start with 30 seconds, 1 minute, and then I wash off the flow seal. I find that the fibrin clot is not as good as when you wait for 1.5 minutes to 2 minutes. For cervical case, although this is a unipodal surgery, I would like to highlight that I use flow seal in thoracic and cervical cases almost in every single case, because any case of bleeding in such areas are actually catastrophic. So we will be more likely that I will use a flowable agent. After we stop bleeding in the nerve roots and the bleeding areas, we also tend not to apply too much radiofrequency in these areas because the cervical nerve roots are more sensitive. So I encourage the use of flowable agent in this case. The situation is similar after we, in terms of unipodal or bipodal. You just need to apply the flow seal until the screen is showing there's a complete whiteout of the granules. and then wash it off. And after 1.5 to 2 minutes, and subsequently, you can see the granules forming fibrin clot at areas where they tend to be bleeding. And you can see from this fibrin clots form. Do not wash them off or do not disrupt the fibrin clots. I find in my experience that they don't actually cause a significant compression if they are just a thin layer of fibrin clot. You can use, of course, we use a drain in some of the cervical cases. And there's evidence to show that if we do biportal surgery, flow seal or flowable agent, that has a less chance of epidural hematoma. Overall, to decrease bleeding, these are the message that I've earlier on highlighted, and we keep the discontinue anticoagulation, and I continue to I only continue anticoagulation usually after 5 days of surgery. We maintain normal thermia. We keep the blood pressure to basically not too high, and MAP around 70 would be good. And then optimal positioning and careful dissection and using appropriate agent. Thank you for your attention.
Thanks, Professor Wu. Thanks for your wonderful speech. 大家都知道，保持内镜下视野的清晰，对保守手术操作的安全性起到一个至关重要的作用。因此，了解椎管内的血管的分布及止血的一些技巧显得非常必要。吴教授今天详细介绍了颈腰椎的椎管内外的血管的一个分布的特点，以及容易出血的一个部位，同时介绍了降低出血的一个方法，包括控压、用药以及体位的摆放、预止血等等。特别强调的是预止血的重要性。其实我们平时强调的一些预止血的重要性，避免出现一些缝平的现象。同时，吴教授也介绍了这一个止血的一些技巧，以及止血工具和材料的一个应用的技巧及时机。再次感谢我们吴教授带来的精彩演讲。谢谢吴教授。下面有请于可怡教授进行下一节的主持。